So, good afternoon, everyone. Hope you're doing well. In today's lecture, which is my lecture number 88 of my lecture series, I'm going to talk to you all about further updates from the ADA. This is my part two of the ADA updates. In part one, also, I have discussed several updates across various sections of the standards of care. In this particular lecture, I'm going to concentrate on the section 8, which is dealing entirely with the management of obesity and overall prevention and treatment of diabetes by weight management. So extremely important session for exam purpose as well as clinical practice and to see the latest updates in this section. Let's start right away. So as I mentioned, I'm going to talk specifically about the obesity and weight management and their role in prevention and treatment of type 2 diabetes. Do not forget to listen my lecture number 86, which has the further updates from the ADA 2025. I'll also be leaving a link for the session below in the description. So talking about the uh, SMART goals first. So we should try to be specific in terms of the weight loss management, have a measurable goal, have an action plan in place, and always be realistic and do it in a timely manner. So always discuss the weight management without any bias or judgment with our patient. Review the history of the obesity focused care. Use motivational interviewing to develop SMART goals for weight loss discussions. So we should always be person-centric. So we should do a focused assessment and learn about the struggles which the patient is going through in terms of his weight, the onset of the weight gain, what are his or her previous attempts for losing weight, what are the barriers preventing him from or her from losing weight, and if there is a family history of obesity as well. Look at the eating habits, look at the hunger and satiation levels, frequency and timing of meals, presence of cravings. What about any triggers for the emotional eating? Assess his current level of activity in terms of noting what exercises he or she is currently doing, looking at the current physical activity levels. In terms of weight, look at the top concerns with current weight and what are the personal goals he or she has decided in terms of weight loss. Always look for complications and screen for complications such as diabetes or prediabetes, hyperlipidemia, hypertension, cardiovascular complication, metabolic associated liver disease, which is a new name for the NASH or NAFLD or fatty liver. Look for any associated depression or low self-esteem because of the high weight, whether it is impairing the quality of life, whether the patient is having any musculoskeletal disorders or joint pain secondary to it. Screen for sleep apnea because new studies have shown benefits of different weight loss medications for sleep apnea. Look for obesity-related cancer risk. Look for PCOS, infertility. Screen for chronic kidney disease as well. So a very important chart from the latest ADA 2025, how we should target and look for counseling the patients with SMART goals. So, as I mentioned, that we should always be person-centric, use person-first language, use a non-judgmental language, never criticize or mention to the patient about their obesity directly. This is important to foster collaboration and reduce stigma. Try and always be person-centric and use a non-judgmental language. BMI remains a screening tool, but should not be the sole diagnostic measure due to limitations. Example, misclassification can happen in patients who are muscular or even in frail individuals. And that's why additional measures have now been proposed. There is also a very recent Lancet article mentioning these additional measures. My next session, my lecture number 89, will be concentrating on that journal article, which is excellent, in which they have talked about looking beyond BMI as a measure of obesity. So look at the waist circumference, 102 centimeters or more in men and 88 centimeters or more in women indicates higher risk. A waist to hip ratio more than 0.9 in men and more than 0.85 in women is high risk. And a waist to height ratio of more than or equal to 0.5 suggests increased cardiometabolic risk. So use these additional measures beyond BMI as well. Clinical actions proposed by the guidelines measure the BMI and waist-related indices, as I mentioned in the previous slide, at least annually to assess obesity risk, assess body composition and weight distribution when BMI is indeterminate, like muscular or frail individuals, ensure always privacy during anthropometric measurements, particularly for the patients with high weight, because they may be distressed because of this. Use always person-first language or person-centric language. Mention person with obesity, not an obese person. So these are important statements from the guidelines. So weight is now one of the primary treatment goals in the management and prevention of type 2 diabetes. This should be emphasized. There is evidence now which shows that 3 to 7% of weight loss improves glycemia, blood pressure, and lipid profile. This I'm talking from the baseline. And more than 10% weight loss from the baseline has greater benefits, including disease modification, cardiovascular improvements, and potential even type 2 diabetes remission. So our target is now the weight. In terms of suggestions by the guidelines, they have suggested, obviously, the three-pronged approach: look for lifestyle changes, suggest for weight loss medications, and suggest for metabolic or bariatric surgery for those patients indicated as per the BMI. So in terms of the lifestyle modifications, we'll look more of this in detail in the next slide. Basically, a dietitian referral, assess nutrition literacy, food preferences, explain benefits for physical activity, set realistic goals, community resources, provide them with leaflets, emphasize the quality and the importance of a quality sleep, assess whether the patient is having sleep apnea or insomnia, and refer to appropriate specialists for the sleep apnea as needed. Stress management, very important. Behavioral health is very important for the overall management. Counsel as regards tobacco cessation, and of course, consider weight loss medications wherever possible. In terms of pharmacotherapy, as mentioned by the guidelines, prescribe always medications as per FDA guidelines. We look at what are the medications mentioned. Consider anti-obesity medications in those who have a BMI of more than or equal to 30 kg per meter square, or BMI of more than or equal to 27 kg per meter square with other comorbidities like diabetes, hypertension, hyperlipidemia, and so on. Surgical management or bariatric surgery is indicated for those who have a BMI of more than or equal to 40 kg per meter square without even medical problems, those with more than or equal to 35 kg per meter square with severe comorbidities, and even consider patients with BMI 30 to 34.9 kg per meter square with type 2 diabetes. So these are all recommendations from the ADA 2025. As I mentioned, the lifestyle modifications ensure that the patient is getting more active and eating healthier. What is the meaning of getting active as per the guidelines? Engage in at least 150 minutes or more of moderate or vigorous physical activity per week. For older adults, this can be flexibility and balance training 2 to 3 times per week. Engage in resistance exercises. This is very clearly emphasized now, especially with more weight loss happening and the chances of muscle loss happening with the weight loss as well. Engage in resistance exercises, weight training 2 to 3 times per week. Always try to move around, interrupt sitting every 30 minutes. Always work with a dietitian and a nutritionist to see what's the right eating plan for you. Always work towards maintaining a healthy diet and a healthy weight. In terms of the diet, you can see the major portion should be of non-starchy vegetables, protein foods with a very small contribution from the carbohydrate food. Always aim for around 500 to 750 kilocal per day energy deficit diet through a personalized eating plan. This is extremely important. And there have been some eating plans provided at diabetesfoodhub.org. You can check them out. This is as advised by the ADA. So now looking specifically for the weight management medications, this is a busy slide, but a very important slide because these are all the FDA approved medications. So we look first at the most popular ones, which is the incretin-based therapy, which are the GLP-1 receptor agonist and dual GIP, GLP-1 receptor agonist therapies. Liraglutide is approved for ages 12 and older. Semaglutide approved for ages 12 and older. And tirzepatide is approved for ages 18 and older. How it works: mimics gut hormone to lower hunger and slow stomach emptying. Start with the lowest dose and increase gradually as tolerated daily or weekly injections. Common side effects we experience is nausea, vomiting, diarrhea, constipation, and very rarely pancreatitis. When to stop is, of course, if there is a persistent abdominal pain or persistent vomiting, and of course, if the patient is pregnant. In terms of the average weight loss, we're talking about obesity only. Liraglutide around 6.2 kg per year. This is as per the studies. 15.3 kg per year for semaglutide and around 20.9 kg after 72 weeks for tirzepatide. This is as per the studies on these particular medications. Additional benefits, liraglutide and semaglutide shown to lower cardiovascular risk in type 2 diabetes. Semaglutide improves symptoms in heart failure and kidney outcomes in diabetic kidney disease. And tirzepatide also reduces liver fat, so helpful in fatty liver, reduces sleep apnea severity, and improves metabolic dysfunction. So it improves all the metabolic dysfunction associated with liver disease as well. These are from the latest studies for tirzepatide as well. Talking about phentermine or topiramate, this is approved for ages 12 and older. It reduces appetite by central action. It influences the central appetite center. Start with a lower dose and increase gradually, taken in the morning with breakfast. Some common side effects encountered is paresthesias, dizziness, taste changes, insomnia, dry mouth, tachycardia, and constipation. Stop when patient has worsening anxiety, chest pain, high blood pressure, or blurry vision secondary to it. Average weight loss of around 9 kg per year. Naltrexone or bupropion approved for 18 years and older. It reduces the cravings by influencing the brain's reward system. Again, start with lowest dose, increase gradually as tolerated. Start in the morning, then twice daily as dose is increased. Common side effects which we can encounter is nausea, vomiting, headaches, sleepiness, sleep disturbances, dizziness, dry mouth, and constipation. Wean off if ineffective or intolerable. Avoid sudden stoppage. Average weight loss of 5 kg per year. In terms of orlistat, approved for ages 12 and older, acts locally in the intestine to prevent fat absorption, taken with meals containing fat up to 3 times daily. Common side effects of oily stools, diarrhea, bloating, flatulence, fecal urgency. When to stop? When we can see the yellowing of skin or eyes, itching, stomach pain, or dark urine, which can be caused by orlistat as a very rare side effect, and it causes an average weight loss of around 3.4 kg per year. Now, if you go further down in terms of the forward on the treatment options a bit more in detail, we already looked at the mechanism of action and the way the things work and the side effects and when to stop. A little bit of more detail about the possible safety concerns. So again, looking at first the GLP-1 receptor agonist and the dual, which is the tirzepatide. Pancreatitis has been reported in clinical trials, but again, causality or whether it is a direct cause has not been established. So it's important to discontinue if pancreatitis is suspected. Then it may also cause cholelithiasis and gallstone-related complications. Again, a very, very rare side effect. In terms of the black box warning, there is a risk of thyroid cell tumors in rodents. However, no human relevance has so far been determined. So these are some of the things which we should keep in mind with our GLP-1 receptor agonist or the dual GLP-1 and GIP. In terms of naltrexone and bupropion, we already looked at, we should consider the side effects which can happen, especially in patients with acute angle closure glaucoma. There is a safety concern. Also, it's contraindicated in patients who have unmanaged hypertension and or seizure disorders, and it's contraindicated for the use with chronic opioid therapy. There is a black box warning for naltrexone or bupropion about the risk of suicidal or behavioral ideation in people younger than 24 years of old who have depression. So keep this in mind when we are going to prescribe this combination of opioid antagonist and antidepressant, which is naltrexone and bupropion. In terms of phentermine or topiramate, these are contraindicated for the use in combination with monoamine oxidase inhibitors, possible safety concerns of birth defects, cognitive impairment, and acute angle closure glaucoma. Orlistat, we already looked at the potential malabsorption which it can cause and the symptoms secondary to it. So it can cause malabsorption of the fat-soluble vitamins like A, D, E, and K, and of certain medications like cyclosporin, thyroid hormone, or anticonvulsants. So keep that in mind. Cholelithiasis and nephrolithiasis has also been reported. In terms of phentermine, we already mentioned use with caution in monoamine oxidase inhibitors, in fact, contraindicated for the use in combination with monoamine oxidase inhibitors. So these are some more details. Side effects I'm not repeating, they were already looked at in the previous slide. So if obesity pharmacotherapy is effective, so what is the meaning of effective obesity pharmacotherapy as per guidelines? Typically defined as more than or equal to 5% weight loss after 3 months of usage. Then further weight loss is likely with continued use and should be continued. When early response to obesity pharmacotherapy is insufficient, like typically less than 5% weight loss after 3 months of use, or if there are significant safety or tolerability issues with the patient for the medication, then evaluate for discontinuation, substitution, or addition of a different treatment approach. It's very clearly defined in the guidelines. So we are going to look more what is mentioned in the latest ADA 2025. They have specified the weight loss efficacy of the glucose lowering medications with very high efficacy reported for semaglutide, both subcutaneous and per oral form, and tirzepatide, high for dulaglutide and liraglutide, intermediate for exenatide, lixisenatide, and SGLT2 inhibitors, and neutral for metformin and DPP4 inhibitor. Again, this is a good overview of the treatment options for overweight and obesity in type 2 diabetes. Obviously, intensive behavioral counseling is a must for all BMI categories. Obesity pharmacotherapy should be considered, as I already mentioned, for those above 30 and about 27 to 29 with other comorbidities as well. And bariatric surgery should be considered. We already looked at for more than 30. And we looked at all the categories where bariatric surgery will already be useful in the previous slides. So this is a further lecture, as I mentioned, to all my other additional lectures. Like I have around 87 lectures so far in my lecture series. This is my 88th lecture. So I've covered the entire spectrum of endocrinology, thyroid, adrenals, pituitary, diabetes, calcium regulation. There are high yield lectures, which includes previous exams recalls, exam labs, Oxford Handbook Pearls. There are quick exam revisions, lectures on reproductive system, lab endocrinology, genetic lectures, and lipid disorders as well. So across my 88 lectures so far, I've covered different guidelines useful for different endocrinology exams, like NICE guidelines, JBDS guidelines, Endocrine Society guidelines, Society of Endocrinology guidelines, ATA, ADA, European Society of Endocrinology, and even ACE. So it's a full endocrinology coverage, which will be very helpful for you all. So please do subscribe to my lecture series. Moving forward, lifestyle recommendations in conjunction with interventions for weight management. So once you start losing the weight, we should also think about what other recommendations are advised by the ADA in conjunction with the weight loss which is happening. So always start slow and increase the dose gradually for these weight loss medications. Eat small, frequent meals. Avoid greasy, sugary foods and strong odor foods. Always stay hydrated, drink good amount of water. Use anti-nausea medications if needed. Engage in 15 to 20 minutes of resistant training exercises 2 or 3 times per week, in addition to aerobic exercises, to prevent loss of muscle mass. This is very important and quoted now in these guidelines. With more weight loss because of these medications, there is a chance of sarcopenia or muscle loss happening. And that's why the guidelines recommended that the patient should engage in 15 to 20 minutes of resistance training activities at least 2 to 3 times a week, which is including weightlifting. Consume at least 30 grams of protein per meal. Focus on plant-based sources. Monitor nutrition status, including fat and water-soluble vitamins, and replace with multivitamins if necessary. So extremely important as well when you're undergoing the weight loss therapy, as now clearly defined in the guidelines. Now, pregnancy and breastfeeding, the recommendation is all weight loss medications, of course, are contraindicated. What about tirzepatide and oral contraceptive? The tirzepatide may reduce the efficacy of oral contraceptives, and that's why they recommend non-oral or barrier methods for 4 weeks after initiation and dose escalation of tirzepatide. So very important in these guidelines. So how do we aim to prevent malnutrition and sarcopenia on these weight loss medications? So rapid weight loss of more than 4 kg per month or more than 20% of the weight loss from the baseline may increase the risk of malnutrition and sarcopenia. So the screening tools has been now defined in the guidelines to help prevent malnutrition and sarcopenia in those undergoing weight loss therapy. That is the simplified nutritional appetite questionnaire and the malnutrition universal screening tool. Preventive things we already discussed: do resistance training, weightlifting, educate protein intake, stay hydrated. So what is this questionnaire? The snack and the must. The snack is taking into consideration 4 questions. The purpose is to look for appetite assessment and weight loss prediction. They focus on appetite and eating habits. The setting is of an elderly hospitalized patient. Outcome is identifies individuals at risk for weight loss. So what is the snack involving? First question is around appetite. Is my appetite very poor, poor, average, good, very good? So they score points based on this question. When I eat, do I feel full after eating? Again, there are 5 points depending upon the response from the patient. Regarding the food taste, and normally I eat, whether I eat less than 1 meal per day, 1 meal per day, or 2 or 3 meals per day, there are different points assigned to that. So if the score of snack is less than or equal to 14, then there is an increased risk of weight loss and malnutrition. So this is what we need to take into context. And if the score is more than 14, this is at a lower risk of weight loss. So this is a good questionnaire for screening patients with risk of malnutrition and sarcopenia in those undergoing weight loss or intense weight loss. Must is malnutrition risk screening. Again, takes into question 3 key factors: BMI, weight loss, and illnesses. General adult population is a setting for it. So any population undergoing weight loss therapy. What is the questionnaire there? So it takes into consideration the BMI. If the BMI is more than 20, score is 0, 18.5 to 20, score is 1. And if less than 18.5, the score is 2 for this step 1. Step 2 is identify unintentional weight loss in the last 3 to 6 months. Less than 5% is assigned 0, 5 to 10% is assigned 1, more than 10% is assigned 2. What is the step 3 is the acute disease effect. Is the patient is acutely ill and has had or is likely to have no nutritional intake for more than 5 days. If yes, add 2 points. If no, add 0 points. Again, more than 2 or more than equal to is defined as high risk. And in this case, we should implement nutritional support and refer to the dietitian, encourage protein intake, and promote exercises, especially resistance training. So further advice about preventing rebound gain. So we have seen that on stopping or discontinuing the weight loss medications, there can be some degree of rebound weight gain. So what is the recommendations and advice in this regards? Taper the medication dosage instead of abrupt cessation, and this may help mitigate weight rebound, particularly for GLP-1 receptor agonist or combined GLP and GIP like tirzepatide. So this is very important in the guidelines. Weight loss must be maintained with continued lifestyle support interventions after stopping medication. So we should make sure patient has appropriate nutritional counseling. Maintain an energy deficit through portion control and nutrient-dense foods. Monitor macronutrient intake, particularly protein, to preserve the lean body mass. Physical activity, aim for around 200 to 300 minutes of exercise per week of moderate intensity exercise. Incorporate resistance training to preserve muscle mass and metabolic rate. In terms of behavioral therapy, monthly or frequent follow-up visits for accountability and relapse prevention, and self-monitoring logging the food intake, weight logs will be extremely useful, thereby reinforcing the lifestyle interventions. Third, consider intermittent or alternative pharmacotherapy, also mentioned in the guidelines. Some patients may benefit from intermittent medication usage, like using a slower dose or lower dose of the GLP-1s, or intermittently using it to prevent significant weight regain. If one agent is discontinued due to side effects, consider switching to an alternative medication with better tolerability. So these are all the advices to help prevent rebound weight gain after discontinuing weight loss medications. So always identify the weight trends closely. I do a follow-up monthly basis. If weight regain exceeds 3 to 5% of the baseline weight, consider reinitiating pharmacotherapy or intensifying lifestyle intervention. So after discontinuing, if the weight loss, discontinuing the weight loss medication, if the weight regain exceeds 3 to 5% of the baseline body weight, again, consider reinitiating pharmacotherapy or intensifying the lifestyle interventions. Regular follow-up, structured program, extremely important. So for accessing my full lecture series, which is 88 lectures so far, please subscribe to my subscription. It's just send me an email at mazirules@gmail.com or simply WhatsApp me on 0097155743479 on WhatsApp as well as the Telegram as well. So with this subscription, you'll get lifetime access to my existing 88 lectures plus all my future lectures lifelong. So wish you all the best. Thank you.